get a little teary-eyed. Yeah. All right, so two major since we know all about triggers in a different way we can trigger the ventilator, how do we know when it's not working correctly? And the two major problems you'll run across is a failure to activate the inspiratory phase when the patient's effort is there, and that problem of auto-triggering, and some of you experienced that when you were breathing on the ventilator and it had a really poor trigger setting. So, failure to trigger could be any one of these. So let's talk about them. And we can see here there are some missed triggers. We're looking at airway pressure. We're looking at esophageal pressure. Now, esophageal pressure is going to mimic pleural pressure very, very well. So there's actually a way to place a catheter into the esophagus and approximate intrapleural pressure. But you can see there's efforts that are here that aren't followed by a positive pressure breath. So we're not in sync. The patient's making effort and getting nothing for it. And it's work of breathing that they're doing, but it's not turning the ventilator on. Could be because the patient is just weak and aren't able to draw enough to trigger the ventilator on. And this is an example of inappropriately set sensitivity, but even a weak patient should be able to trigger it on if we have the setting correctly. When it's set properly, again, we saw this last time, that there's a big delay that is there. And this is somebody who, for whatever reason, the sensitivity isn't set appropriately. See this a lot again on home ventilators, and we see this. Some of the home ventilators have external PEEP adapters. Normally, you and I, when we go to the ventilator, we dial in the PEEP setting, and everybody knows what the PEEP is, and the ventilator ties that sensitivity to the PEEP setting. If I have an external PEEP valve, they have no idea what the PEEP level is. So we have to adjust the sensitivity to compensate for that. If we don't, it's not going to be able to trigger it on easily. Breathing treatments, especially when we're using a nebulizer powered by a flow meter off the wall. In that case, what you end up having is you have some additional flow being added to the circuitry, and that can trick the ventilator also. Patient effort, no ventilator breath. So the extra flow tricks the ventilator into thinking that there's not a patient effort there, because they got to draw through that flow to be able to trigger the ventilator on. What we can do, if we're using that, we need to adjust, either turn the rate up so that there's not a need for them to trigger, or especially with continuous flow systems like we see on infant ventilators, you may need to adjust the continuous flow downward to compensate for the flow that we're adding into the circuitry. You can also use an MDI. We can use an aerogen nebulizer, which is an ultrasonic. It's not truly, but it's along that line. In other words, there's no bias flow being added. If you have a ventilator that has the ability to only provide flow on inspiration, some of them, when you there's a nebulization activation, and will only power the nebulizer during inspiration, or you can instill the medication. That's not that commonly done. But for the first two are your two most common ways that we can combat this problem. Failure to trigger can be caused by auto-PEEP. I think Lori talked about this over the summer, but basically whenever you don't have the flow tracing coming back to baseline, I have auto-PEEP present. I just don't know how much it is. Remember back, we are talking about our applied PEEP, which is what we set, also known as extrinsic, and the auto-PEEP is what is trapped, and the total PEEP is the sum of the two of them. So there's my applied PEEP, raising the baseline, increasing mean airway pressure, improving oxygenation. And we know that as we have a patient exhaling, if they exhale back down to complete collapse, sometimes that auto-PEEP or placement of PEEP, excuse me, will keep those alveoli open and keep them stable. This is just looking at under normal conditions when the alveoli on exhalation they don't completely collapse off, and that's where we get that severely diseased ARDS type lung. You have a very limited amount of inflation, which leads to horrendous VQ mismatching. How do I know if I set applied PEEP correctly? Multiple ways to do that. I should actually pull out my article that I wrote on this, optimal PEEP. But if there's not enough, I'm still going to have shunting. I'm still going to have a PaO2 that's not adequate, or PF ratio that's not desired. Still have atelectasis on the chest X-ray, and the compliance, if we measure, will still be low. PEEP is not without problems. We know that as we get too high, we end up having cardiovascular compromise, especially when we're starting to see the plateau pressure above 30. And if we are monitoring it, dead space, either by using an Untitled CO2 monitor that has flow integration. Has anybody done at Children's? Have you guys seen the, it's not the Cosmo, no. I'll think of it. But it's an Untitled CO2 monitor has a flow sensor on it, so it integrates the flow signal with the Untitled CO2 signal. So you can actually get a true dead space fraction without having to actually do a Douglas bag in using the Pico. So this is an idea of how we do a PEEP study. Let me just kind of give you some numbers here. Make them up as I go. So let's say at 5 of PEEP, I have a PIP of 30. I have a plateau of 20. I have a compliance measurement of, let's say, 30, and that's in milliliters per centimeter of water. I have a blood pressure of 110 over 70, heart rate of, let's say, 100, SpO2 of, let's say, 90, PaO2 of 60. Auto-PEEP is, we'll go with 0 for all of these, so we're not playing games with that. And increased work of breathing. When I add to 10 of PEEP, my peak pressure is going to rise. My plateau pressure, let's say, gets a little bit better. My compliance gets a little bit better. My blood pressure is still okay. Heart rate's the same. SAT goes up a little. PO2 goes up a little. Work of breathing goes down a little bit. At 15 of PEEP, my peak pressure now goes up. My plateau pressure goes down. My compliance goes down. My blood pressure goes down. My heart rate goes up. My SpO2 goes down. PO2 goes down. Work of breathing goes back up. At this point, we would say that that is a degradation in cardiovascular function. It's also a loss of compliance. Both of those factors can be used to say that the optimal PEEP then is 10. So we should return back to 10. I will guarantee you will see on your board exam a question of this nature. Guaranteed, guaranteed, guaranteed. It's one of their favorite types of questions. Determining the optimal PEEP using one of a bunch of different techniques. Compliance is a favorite one. Plateau pressure is a favorite one. Cardiac output or blood pressure is a favorite one. Oxygenation is a favorite one. But you got to kind of take it as a gestalt. You got to take all of them together. You can't just say one value and hang your hat on that. Okay?
Why am I seeing a decrease in compliance? Something's changing with the
Because I'm overdistended.
Because it's affecting the heart because the lungs are becoming overextended.
Right. absolutely. Common style problem, though. And clinically, there are many institutions who still do optimal PEEP studies when they set somebody up, especially in ARDS. So, what the favorite one is, I don't know. I'll see if I can find the article that I wrote, though. Get it for you. So what about this thing called Auto-PEEP? Well, first of all, we're going to use the flow time curve to be able to determine the presence of it. If I do an expiratory hold maneuver, which is what you do when you measure Auto-PEEP on the ventilators itself, it locks the valve and does not allow gas to escape from the circuitry. Any trapped gas then is allowed to equilibrate across the system, and you'll see the pressure rise on the pressure time tracing. You also might see air trapping on the presence on the volume time curve. Specifically when that expiratory hold maneuver, you'll see some rise in volume. And what we normally will see is an alteration where it doesn't come back to baseline. It looks like a leak, but it's not on every breath. If I have this kind of a picture where I have every breath having the same volume not returning, that's a leak. If I only see that on an occasional breath, that's air trapping, and that's Auto-PEEP being present, or potentially being present. And again, if we measure our PEEP, I have, you can see this pressure rise up. There's an additional amount of PEEP, so I have a set PEEP of 5. I have a total PEEP of 13. That means I must have an Auto-PEEP of 8. Again, the exhalation valve closes. We're normally on 0 set PEEP. We rise up into whatever that distance is how much exhale volume we have. And you can see that exhale volume being measured on the volume tracing. This could be also that it's just out of calibration, but assuming that we have a calibrated flow sensor, when we're seeing that kind of a thing, it's probably the Auto-PEEP being present. And what that means then is that it's difficult for the patient to trigger the ventilator because they have this amount of extra PEEP that they have to draw through, this amount of dynamic hyperinflation that they have to fight against. This is a graphic that you probably don't want to know about.
We're not going to graph that one.
We're not going to graph this one. And disaster when they come at the same time. I just thought that was a good one. So let's go ahead and take a look at lab number 2. And let me see if I can find a blank sheet. Let me try doing it on screen. There we go. And I want to have So let's do the volume ventilation one first. What is our starting point when we're looking at a volume-based breath? What do I want to draw first? Oh, this won't work. Sugar. Pen here. Here we go. So I'm going to draw the flow first. Okay, so it's the middle tracing. And what do I want the flow to be? 30, and it's a square wave. So I'll make this 10, 20, It's going to be a challenge. You can see this already. And this will be 30. I know, it's going to be a challenge, guys. You got to bear with me. Square wave. What's my inspiratory time? 1 second, thank God. Let me see if I can, maybe make this pencil thicker. Well, I want to get it so it's being recorded. And then I have my expiratory portion. Oops. I'm an eraser here. Let's try that again. My next breath, I'm on a rate of 20. So that means every 3 seconds I should have another breath. 1, 2, 3. So I should have one. This is a lot harder than it looks. Does that make sense?
Yep.
I'm going to document the presence of Auto-PEEP. And I have my square wave flow curve, and it's not returning to baseline at the start of the next breath. I have a rate of 20, so there's 3 seconds between, and I wanted it a 1 to 2 IE ratio, which I do indeed have. What is my pressure tracing going to look like with a square wave flow pattern? It'll go straight up initially, and it doesn't need to go up. But first of all, I need to find out what kind of baseline I'm on. PEEP 5. And I want a pressure of 25. Okay. So here's my, we'll make this 5. 10, 15, 20, 25. I know it's terrible here.
But you have to auto, you got to trigger itself.
Oops, went too far on that. Imagine there's a little trigger there. I can't draw one. And my volume I would end up having, again, tidal volume is 500. So we'll assume that each one of these is 100 going up. 1, 2, 3, 4, 5. Oh, that's a real good one. And just to simulate, we may see something like this where it doesn't come back to baseline. Huh? Horrendous. Patient trigger, begins the breath, pressurizes as a straight line, pressurized based upon a square waveform, volume goes in, volume comes out. Notice that the flow doesn't come back to baseline, telling us that we have auto-PEEP present. How much auto-PEEP, we don't know. We just know that we have it. Better? Not a chance, I know.
Yesterday, I was doing some of these and actually got to go on the RT to the ventilator and we were looking at the waveforms and stuff like that.
Good, that's what...
So, and that was really helpful because then I looked at this and then I took all of her
settings,
settings.
And you drew it.
I drew it out.
And you compared it to what you actually saw.
Mm-hmm.
That's the game.
Yeah.
The only part you don't know is the expiratory portion.
Yeah.
That is really dependent upon each individual patient is going to be different, that you're going to change. But if you set a ventilator up with specific settings and change compliance and resistance, you're not going to see an alteration in the shape of this. If you're in volume-based ventilation, it's always going to stay the same. What you'll see is a change in pressure. As you change compliance and resistance. That's the whole idea of a volume-based breath. Okay. Okay, now let's see how I would go about doing this if I... No. Let's do this if it's a pressure-based breath. Okay. So it's all machine breaths, a flow of 60, a peak flow at least, a frequency of 20, 1 second eye time, okay, 5 and 25. So here we're going to start with the pressure tracing. Because I got a pressure-based breath, I'll go ahead and make 10, 15, 20. $10, 15, 20, 25.
Is your starting point at 0?
No, my starting point is 0.
Is that 0?
No, 5. You're in baseline of 5, right? Yes. And I have a rate of 20, so I need to go okay. Again, can't see auto-PEEP from the pressure tracing, you can only see it from the flow tracing. What does the flow curve look like in auto-PEEP, or with pressure-based breath? No.
Oh, the erected one.
The
Right?
erected one.
That one where it goes up and then it like squiggles down.
Well, kind of, sort of. Now, let's see if I can get it. It's called exponential decay is the fancy name for it.
I was way off.
The erect one, right.
Yeah.
Like that. And then they're going to have an expiratory portion. But again, before the start of the next breath, it doesn't return to baseline. It's really hard to get something close without touching it there. Oh, he's had an awful looking one. That exponential decay should look something like that. Please, when you're trying, don't make it a straight line. This is a decelerating ramp, totally different than that one. And volume, vital volume is 500 again. 2, 3, 4, 5. 1, 2. This may be an example where it doesn't come completely back to baseline. They stop you. Get out of there. Getting better? Yeah, the volume really here should line up with this.
Yeah, that's
Yeah.
and that one will come up, but it won't go back to baseline.
It may or may not.
Okay, so.
Yeah, because with Auto-PEEP, what you end up having is you have what appears like some, like all the gas is emptying out, and then on another breath it doesn't, and then it builds up, and then what you can actually get at some point is volume that actually goes below the baseline. So my inspired is here, and my expired goes down here, because I'm now getting to fully exhale all that trapped gas.
Yeah. Well, it's like how it says only a few breaths, so it's not every breath.
Exactly.
Only a few breaths.
Exactly. In fact, some you'll actually, where they're exhaling more than you put in. How the hell is that possible? Well, that's quite possible. Have you measured on a 840 and did the compliance and resistance and got a parentheses? We haven't encountered that yet. What that's saying is that it's seeing exhaled gas greater than what we'd put in. How is that possible? I got COPD with air trapping. Not necessarily Auto-PEEP, but it's there. In that case, what do? Well, you do the measurement multiple times, and if I'm seeing a consistency in the value, it's an acceptable value. Okay, we good there? You guys are just so excited. I don't know how you can control yourself. All right. So what do we do, or what are some of the causes of Auto-PEEP? First of all, insufficient time to exhale. And it could be a combination of any one of those three. It could be some obstructive element, especially if an HME gets wet over time. Become it. Or it could be the airway itself becoming obstructed. Severe airflow obstruction, like from a tumor or a mass. Dynamic airway collapse, like you see in asthma or emphysema, or poor secretions that are become thick due to poor humidification. So how do I take care of this Auto-PEEP? Well, really what we should focus on is making sure there's enough time to exhale. Remember back over the summer you learned about time constants and talking about you need 3 time constants to fully exhale. Take a look at a patient who's got COPD who has a high airway resistance and very high compliance. Multiply those two together and you're going to get a time constant that's very long. And if we don't allow for adequate time, we're going to have air trapping in the process. If it's something to do with the airway or the circuit, well, we can fix that. Replace the HME. Use the rescue cast to clear out the lumen of the endotracheal tube. Anything we can do to have them exhale more completely. If I want to increase the time to exhale, I have to increase the expiratory time. In volume ventilation, that means that I have to either decrease the rate, assuming they're controlled, because the patient can just breathe over it if not, or perhaps even considering something like SIMV, where some of the breaths are their spontaneous breaths and they're able to regulate the I time much more effectively. Same is true when you're looking at pressure-based breaths. I can decrease the inspiratory time by increasing the peak flow and volume ventilation, or decreasing the inspiratory time in pressure-based, since that is one of the settings that we have. And when we get to pressure-based, pressure-supported breaths, We can do things like altering the rise time and the E-sense, and we'll talk more about them in another lecture. Decreased tidal volume or minute ventilation. Well, volume-based ventilation, it's pretty easy, just reduce the volume. We can also do the same thing in pressure-based ventilation if we believe that the volume is too large by decreasing the inspiratory pressure. If there's any plateaus present, definitely removing them, although we don't see plateaus utilized that often. Making sure that it's not auto-triggering that's causing the auto-PEEP. We'll notice that by having two breaths stacked upon each other, and if need be, sedation or even paralyzation if it's paralysis if it's that significant. Removing obstructions, things like, as I mentioned, the HMEs, expiratory filters, expiratory valves, water in the circuitry. If they're biting or the tube is kinked, making sure that we get it clear, and certainly looking things like, as I mentioned, using a rescue cath or suction and making sure the humidification is adequate to remove secretions. And then as far as any airflow obstruction, if they need to be bronchodilated, certainly that's an indication, and if it's severe enough, perhaps bronchoscopy or even heliox if the status asthmaticus is that profound in the process. How do I know a bronchodilator works? I look at the expiratory peak flow, just like you do in the ER on an asthmatic. Same idea. If I'm not seeing consistent improvement in peak flow when I administer a bronchodilator, the question should be raised, am I giving enough? Because if I'm not seeing any change, that's the purpose of that drug last time I checked, is to improve expiratory peak flow. If it can't still not, everything else has not worked, we can add applied PEEP. We could do this by adding up to 80% of whatever auto-PEEP you measure. I can add applied PEEP. And what that'll do is it'll bring the trigger point closer to the patient lung pressure, and they won't have as much work of breathing to trigger. And again, do not add applied PEEP if the patient is not attempting to trigger. If not, in other words, if there's riding the ventilator. And we can use NABA or some other type of triggering that doesn't require a pressure change to be able to be sensed. I love this one. Twoo, it's twoo. Okay. So we did this in our graphing exercise. We ended up adding auto-PEEP to that 2 scenarios that we ended up having. And there's a lab assignment that we can end up doing, but let me keep on going here for a little bit and talk about auto-triggering. This usually is either a situation where I have a leak or I have improper sensitivity settings, and when you guys were playing with the ventilator, if you had, when you were on a pressure of -20 to trigger the ventilator on, I noticed a lot of you were stacking breaths there. So basically, auto-triggering is defined as turning the vent on, going to the inspiratory phase without an effort from the patient. And it usually is either sensitivity set improperly or leaks, especially when you have PEEP present. And the same cardiac oscillations you'll see on a rare occasion, but it can end up happening. So here I have multiple breaths stacked upon each other, and that's going to be uncomfortable to the patient, to say the least. Here, what I'm seeing here, these little efforts, are not patient efforts. That's actually the heart beating so hard within the chest that it's altering the airway pressure. And you can actually get triggering secondary to that. It's an interesting little phenomenon. And we talked about leaks. When there's a leak present, you end up having that breath triggered on prematurely. How do you know you have a leak? You can hear it. You can see it. When your volumes aren't the same of what's going in as what's coming out. And looking at graphics as far as the loss of PEEP, and looking at the volume time curve or the flow volume or pressure volume loops. So here I end up having every breath. That's a good sign that you got a leak. If I have this just on one breath, again, it could just be auto-PEEP. How to correct the triggering? Well, make sure the sensitivity is set correct. Checking for leaks within the system, changing from flow to pressure if needed, using some other type of triggering if it's available. And then if you're using something where I'm adding flow to the circuitry, stop doing that and using an MDI or a Aerogen, and then getting rid of air trapping and auto-PEEP. Questions on trigger problems? Okay, in the time remaining then, let's go ahead and do the lab.